next speaker is a longtime advocate turned biotech founder. Reason has built Repair Biotechnologies around a simple but powerful idea. Aging is damage, and damage can be repaired. His company has developed his company is developing therapies aimed at targeting the root cause of aging, including immune aging and osteosclerosis. Please welcome founder and CEO of Repair Biotechnologies, Reason.
Okay, so this one? Yes, excellent. So first approximation, what is it we do? Sorry? The lower one. Here you go, see? Okay, so to the first approximation, what do we care about? We care about atherosclerosis. We care about the problem that everybody has, which is that you get fatty plaques growing in your arteries, and this kills a quarter of humanity through stroke and heart attack when these plaques rupture and cause a blockage downstream. And unfortunately, for the average patient, the present treatments do nothing but slightly slow this condition down. If you have it, you're not getting rid of it. And that's a problem. So, what to do about that problem? At the very high level, we've produced a therapy that can actually get rid of the plaque, and that's what you really want to do here, and that's what nobody else has managed to do. And we produce very dramatic, very rapid regression of plaque in animal models, and we do that by targeting what was previously a fairly unrecognized critical mechanism in the disease, and I'll get to that in the course of it. Now, everybody knows that everybody's physician, after you get to a certain age, you're told keep your LDL cholesterol low, and the whole industry and the whole of medicine has sort of glommed onto this thing as the be-all and end-all. But in fact, if you lower your LDL cholesterol as low as it can go, the average outcome after years of using these therapies is that your plaque stays put. It doesn't go away. You get a 0% reduction. In fact, meta-analyses show that it's sort of like 3% to -3% to +5% is sort of the normal human range, and most people are at 0 or slight increase. These are not curative therapies, and that is fundamentally a problem. So, apologies for this is the hammer the idea home version of this deck. The problem is that a quarter of humanity is dying, and present attempts at therapy are not solving the problem. So what is solving the problem? I talked about LDL cholesterol, and to take an idea from Apple, you got to rethink this. You got to rethink cholesterol in this problem. And the circle on the left here, in order to rethink it, you have to talk a little bit about cholesterol and cholesterol transport. The circle on the left is a very oversimplified version of what's going on in your body, which is that cholesterol is largely made in the liver. We're not going to talk about the brain. There's a different thing going on in there. Cholesterol is largely made in the liver. It goes out through forward cholesterol transport to everywhere it's needed in the body. Cholesterol is not made and destroyed locally like many proteins and compounds are in the body. It's made in one place. It goes to where it's needed. If there's too much of it, it gets picked up, thrown back into the bloodstream, and sent back in reverse cholesterol transport. And this is enormously complicated. It's regulated in ways that are not fully understood. There's many different particles involved. There's many different cell types involved. And like all complicated things, if you get old, heaven forbid, or you get fat, then it goes awry. And the way in which it goes awry that's really important is local excess of cholesterol. Now, local excess is a problem because it causes pathology. Cholesterol, actually unmodified cholesterol, this thing that's vital to every cell in your body, is toxic. If it's not in a cell membrane, if it's not being esterified into lipid droplets, if it's not attached to a transport particle and is roaming around your body, it's toxic. So any place in your body where you have a lump of fat, there's mostly cholesterol, those cells are not happy. There's a limited number of things they can do to prevent that from being toxic. They get too much cholesterol inside them. So the difference between somebody with a fatty liver and someone without a fatty liver is that if you have a fatty liver, your cells are drowned in cholesterol and they're changing their behavior, and some of them are dying. And they can't really do anything about this, and frankly, this is an undruggable target. There's no breakdown cholesterol mechanism that operates in cells, so you can't get a small molecule to go in there and mess with that because it doesn't exist. And you can't use something like a cyclodextrin to bind the amount of fat inside cells you need to get rid of to solve the problem, because it would destroy your bloodstream, it would destroy your organs at the levels of drug that you would need to actually make a difference to these cholesterol deposits. So this is why nobody's looked at this, really, to date. You need something that isn't a small molecule to actually address this. So how do you address this? Well, our drug, which we're calling REP3 for now, actually selectively targets just that toxic free cholesterol inside cells, not all the rest of the cholesterol that a cell has it's making good use of. So its current manifestation is a lipid nanoparticle that delivers mRNA, and that mRNA expresses a fusion protein. The fusion protein is made up of several human genes that don't exist in combination in most cells. They aren't expressed in combination in most cells, but if you join them together and put them all in one place, they break down free cholesterol, and only free cholesterol. There's a fun story I can tell you later offline about how this research program came out of oil spills in the Gulf, but that's a whole different thing. Too long for here. So if you can break down this free cholesterol, the problem goes away. So it's just a matter of getting this fusion protein into the places you need to get it. Now, our big important realization is that you don't actually need to get this protein everywhere. You only need to get it into the liver. If you get it into the liver and remove the excess free cholesterol in liver cells, then suddenly the liver thinks, wow, I need more cholesterol. It's like pulling the bath plug at the end of the bath. All the water goes in that direction. So the body re-regulates to upregulate reverse cholesterol transport, which is taking free cholesterol back from the rest of the body to the liver. And in the course of doing this, it dramatically reduces inflammation, because you're resolving a pathology that exists throughout the body wherever there is too much free cholesterol by making the liver pull it all back to the liver, and then when it gets there, it gets broken down by our drug. So you need three things to reverse atherosclerosis. The first thing is you need to remove free cholesterol from the liver. Second thing, you need to remove free cholesterol from the rest of the body and get rid of it from the liver when it gets back there. And the third thing is you need to dramatically reduce inflammation. If you don't have any one of those, you're not going to reverse atherosclerosis. But if you do, what's happening here is you're restoring the body's natural ability that it operates in youth to actually get rid of atherosclerotic lesions. 5-year-olds have fatty streaks in their arteries. 10-year-olds do not die from atherosclerosis. The body can reverse atherosclerosis, but it stops being able to do it as you get older or you get fatter. And we're restoring that. Now, that's what makes us different from every other company in this space, because every other company in this space is looking at what makes plaque grow, and they're trying to reduce that. But none of those approaches can actually cause plaque to reverse, because none of them are working on mechanisms of reversal, if that makes sense. So we put this in mice, right? We get enormous plaque regression, very rapid. We get stabilization of the unstable plaques. We don't get any of the side effects you see with statins. The mice exercise more effectively. The liver becomes healthier. It's pretty amazing. I'm going to show you a couple of slides here with some data on it. So 6 weeks of treatment, 20% regression of plaque size in the aortic root. The things on the left there are cross sections across the top of the heart. You're looking at valves around the circle there, and the red is plaque. But the graph tells the story. You get this is in LDLR knockout mice, which is a model of human homozygous familial hypercholesterolemia, where patients die at age 30 or thereabouts from stroke and heart attack. They have very aggressively accelerated atherosclerosis. And they're not the only people with too much plaque that needs to go away. But it's not just the aortic root where you get these really huge plaques. It's all throughout the system. So this is the aorta. Hopefully you can see this. On the left, you have aortas, the whole length of it. You slice it lengthways, you unroll it, you stain it for plaque, which is the red parts. And you see these small plaques get reduced by up to 30%, again, in 6 weeks of treatment. And if it's happening here, it's happening throughout the vasculature everywhere. All the places you can't stent, all the places you can't see, they're all seeing plaque regression very rapidly because we're enabling these mechanisms. This is an interesting, last data slide I'll show you. This is an interesting representation of the reduction in inflammation. Here you're seeing a very well-known pathology-connected cell type, CD68 plus macrophages. They're inflammatory, they're unhappy, they sit in plaque, they are very well established in the literature to contribute to plaque formation, and people have shown that you can slow plaque growth by getting rid of them. And we get rid of nearly all of them. A dramatic reduction in them. The red staining is these horrible macrophages. So this is all good. This is all what you want to see in a therapy that's actually curative for cardiovascular disease. You want to see plaque regression. So it's not just atherosclerosis that's our current focus. And in fact, we're probably going to Australia first for a clinical trial. And you can't run rare disease trials in Australia. Australia doesn't have enough people to do really rare diseases. So you can do something like acute coronary syndrome, where many of the patients have really severe plaque to the point where they have pain. They have angina at rest or while exercising, and you can do a study and see that reduced, and it would be great. And we probably won't continue with that. We'd rather go with a rare disease in North America and worldwide, which is homozygous familial hypercholesterolemia, where they have vastly elevated blood cholesterol throughout their life. And they also have, interestingly, very well documented exercise intolerance. So you can go in there and do trials and show that you can restore patients' exercise tolerance based on our data in mice, and this gives you quite a rapid path to the clinic relative to trying to do something more prevalent. We had a FDA meeting in January, and they basically said, "Thumbs up. This looks great. Go for it," which is kind of what you want to hear. And our path to the clinic, as mentioned, pretty fast. I should note that no cardiovascular company has succeeded in getting to clinical trials without getting acquired first. So it's highly unlikely that we'll be still an independent company by 2030. We'll probably get acquired very rapidly after our first data showing that you can regress plaque in humans. But you still need the plan. And the plan is rare disease approval in 2030. So after that, the unifying theme of everything we want to treat with this drug first is that all of these various conditions involve severe atherosclerosis to the point where your arteries are narrowed and your risk of death is very high. Ideally, in the severe atherosclerosis in the general population, you're looking at the 10 to 20 million people who are going to die in the next year or two, and nothing that the medical community can do to them is going to do anything right now. You can't help these people. They're just going to die. And it's incredible that we're in this situation. So we can help. Beyond that, think of everything that obesity makes worse. Every single disease that obesity makes worse, some component of that is because these people have so much cholesterol in their systems that it's screwing up every tissue. So MASH, the metabolic steatohepatitis, metabolic dysfunction associated steatohepatitis, the new name for non-alcoholic fatty liver disease, is a good place to go. We've shown that we can reverse fibrosis very aggressively, very rapidly in those models. But neurodegenerative conditions are perhaps the most interesting. It's becoming very clear that dysfunctional lipid metabolism is important in these conditions. You see lipid droplets in microglia and other cells in the brain. And again, there's every reason to think that our approach to therapy can come in there and actually do something amazing where people have struggled to date with that because they really weren't addressing that pathology at all. Nobody has addressed this pathology so far. And if I haven't made the point already, you can't address local deposits of cholesterol by lowering blood cholesterol. It doesn't make any difference over the time frame of like 4 years or 10 years. Over a lifetime, sure, but not in the later stages of life when you're getting treated. So we've got amazing licensees and partners. We've licensed this technology from the University of South Alabama. We have a global exclusive license indefinitely, pretty much, on this. And Genevant, who's sort of the 800-pound gorilla in the lipid nanoparticle space, provides our lipid nanoparticle technologies. And we've expanded this patent tree considerably since we started. I think we've improved the efficacy of this something like 16-fold from the naive implementation of the fusion protein to what we have now, which is really highly effective. And hopefully I don't need to make the case too aggressively that cardiovascular disease is actually a really big market, and it's really important to change some of the numbers here. But some of the numbers are kind of shocking. Like the cost to payers for one human being's cardiovascular disease over the course of their life is something like $750,000. So this is why cardiovascular companies that are only doing a little bit to change that number are enormously valuable, because it's a huge, huge market. Just the drugs alone, which is probably a modest fraction of the overall cost of coping with cardiovascular disease, is sort of a $160 billion market. And we should be able to capture most of that. So The other interesting little factoid here is if you get a 1% reduction in plaque volume because you're one of the lucky few who responds well to statins, then your risk of heart attack and stroke drops by 20%. So as you'll note, we do a 20 to 30% reduction in plaque in 6 weeks with just one course of treatment. Now you can take a guess at what that's going to do to heart attack risk and stroke risk. And that's what we want to achieve at the end of the day, an end to heart attack and stroke, an end to cardiovascular mortality. And we have a technology that I think offers that potential. You know, there's a chance of achieving that outcome by following this path. And victory for us is convincing pharma that this is actually something they should be doing and having a new statin explosion, except instead of statins, you have actual curative therapies being developed and Me Too therapies by everybody in the game because they realize that this is the way forward. So we're a small company. I mean, we're a tiny lab attached to a big money pipe, effectively. So we run a lab with 7 employees up in Syracuse, and it's a really nice place to do science in the middle of a bunch of universities. Cost is very low. I mean, we spend about as much on our rent in a year as somebody in Boston spends in a month, I think. You know, it's a good place to be. So us in a nutshell, I mean, you guys know who I am. Morad, I think a lot of you have met him, our CSO. He's out there in the lab right now, helping the team do a bunch of study takedowns. Bobby Khan, our CMO, is very well connected, an atherosclerosis-focused physician. He's put drugs through the FDA and knows the environment very well. And we have a great scientific advisory board. And I'll just direct your attention that Deepak Bhatt came on this year. He's a very big name in the cardiovascular field, has run some of the most important clinical trials in recent years, and thinks that what we have is really important. Similarly, Ronald Carlsberg is a very big figure in the imaging side of the cardiovascular space, and he's actually leader of a sort of a crusade to try to get the FDA to stop using LDL cholesterol as a surrogate endpoint and start doing plaque regression instead. And obviously, this has gone about as well as you can imagine because pharma has absolutely zero interest in that outcome. But this is the sort of the zeitgeist in the medical community. They want plaque regression. This has to be the way forward. We can't just keep producing therapies that produce, a 10% reduction in mortality and basically no effect on the people who have the worst plaque. This has to stop. That's why these people are on our board of advisors. They want to see change. So with that, the thought that change is possible, I will stop and happy to take questions in what time remains.
A4LI is very interested in accelerating the rate that we can get things into humans, like compassionate use and right to try. Between now and 2030, there's going to be a lot of people that die of cardiovascular disease. What do you think of is there any potential to go faster?
I mean, the real challenge here, okay, so at the high level, you could take over the government and say, okay, the FDA is no longer assessing efficacy. Or now everything runs like Australia, therefore costs are half as much and time is half as much to get phase 1 done. Yep. The real challenge in doing anything more than that lies in the fact that the existing establishment is exceedingly hostile to people who go outside. If you want to see your company's reputation destroyed and your personal reputation destroyed, go do something in Prospera. This is not to cast aspersions on their efforts to try to be an alternative place. It's just it's realistically just true that you will get a lot of character assassination from the powers that be and those that are interested in maintaining the existing regulatory environment. And that's a really big problem. It makes it very hard to do anything more than, let's say, go to Australia. And Australia is to be commended for championing something where they've actually beaten that back and successfully produced a much better regulatory system that's still not as far as I would have gone in my ideal world, but has in the real politic world, they've actually succeeded, and you don't get shot for going to Australia, even though it costs half as much, and you're not putting full GMP materials into humans. Why can't we just Why can't we just do that for everything? That would be great.
First of all, it's nice to see that your enthusiasm is there. Once we were dying because we had no thymus. Now your enthusiasm is somewhere else. So keep it going. I really missed two things. First of all, the mRNA, how is it going to be delivered?
Right, you're looking at a GalNAc conjugated lipid nanoparticle. So it's exclusive.
Delivered how?
Oh, systemic injection.
Through the
Yeah,
vein?
intravenous, yes.
Okay. Every day?
No,
You don't know yet.
Once a week for 8 weeks is our current sort of, we're going to try this in humans and then see how it goes. Ultimately, the clinical community is going to have to decide, how long should you run a program. The lipid nanoparticle we currently use is one where you should sort of, take a break for a few months after a couple of months, but how often do you repeat the therapy? There's no way to establish that.
Right, but it's an invasive therapy. The second thing is, which model did you use? The cholesterol in the plaque is very different biology than cholesterol in the liver. What models did you use to show that you're actually clearing plaques from the coronary?
Right, so the LDL model is the one we focus on primarily because obviously we're aiming at homozygous familial hypercholesterolemia, and that's the direct representation of that disease, and it translates very well. We've also used ApoE knockout mice. We see basically the same results, a little more muted because the ApoE knockout mice have disabled reverse cholesterol transport. And the fact that those results are more muted in that mice shows that the reverse cholesterol transport is actually important. We've also done some studies in aged black 6 mice, not many, because obviously you have to, it takes about a year and a half to get to the point of anything meaningful in those models. And we're also right now running a safety and feasibility study in cynomolgus macaques in order to see how it does in a non-human primate with the human version of the drug. So plenty of data, lots of different models.
But no pigs?
But no pigs, and probably never any pigs.